Hello everyone, my name is Jenna DeCola and I'm going to be telling you about Murray Valley encephalitis, dengue fever, and Powassan virus today. Let's get started. All right, we're going to begin with Murray Valley encephalitis, or MVE for short, and we'll begin with the causative agent and transmission. So MVE virus is also known as an arbovirus because it is transmitted by arthropods, specifically Culex annulirostris mosquito. It's spread from infected animals to humans by these mosquito bites. There is no direct person-to-person spread. In Victoria, the primary hosts of MVE virus during years of high virus activity are water birds, specifically herons, cormorants, and darters. They're the most commonly infected. Mosquitoes become infected with the virus when they feed on people or animals that are infected. The incubation period can range from 7 to 28 days, and infection with Murray Valley encephalitis confers lifelong immunity, so individuals cannot become infected again. Moving on to symptoms. Many people infected with Murray Valley encephalitis virus actually do not display symptoms, or they have very mild symptoms. So in the case of mild illness, symptoms may present as fever, headache, nausea, vomiting, irritability, and specifically in infants, floppiness. 1 in 1,000 infected people approximately symptoms worsen with drowsiness, confusion, neck stiffness, tremors, and seizures. These seizures can indicate progression of meningitis, which, as we know, is an inflammation of the lining of the brain and spinal cord, or encephalitis, infection or inflammation of the brain itself. Moving on to diagnosis. Diagnosis of MVE is made by a blood test or detecting the virus in CSF, or cerebrospinal fluid. An infection is confirmed by a significant rise in antibody titer to the virus in 2 specimens that are taken 7 to 10 days apart. Both polymerase chain reaction, or PCR, testing, which detects the genetic material in the virus in the blood, as well as serological testing, which tests the involvement of the detection of specific virus immunoglobulin M antibodies for MVE virus, are performed. A diagnosis of Murray Valley encephalitis should be considered in any patient who presents with encephalitis and who has been to the Murray Valley area within the incubation period of the disease, especially during the months of November and March, when the disease is most prevalent to be transmitted. MVE may also be acquired at any time in the northern parts of Australia or in Papua New Guinea. Moving on to epidemiology. Murray Valley encephalitis virus was first isolated from patients who died from encephalitis in the Murray Valley in Victoria in southern Australia in 1951. So travelers to New Guinea and remote northwestern Australia or southeastern Australia are most at risk of acquiring the MVE virus. The virus, as I mentioned, is more common during times of heavy rainfall, which leads to flooding, as well as hot and humid weather. So travelers who spend a lot of time outdoors or will be in an area with a lot of mosquitoes are at increased risk of getting the virus. One of the main theories of outbreak causations is that the virus is carried from northern parts of Australia by the birds that are migrating south in search of food after heavy rainfall. MVE virus is endemic or always present in northern Australia and most likely in Papua New Guinea as well, but illness in humans is actually rare. Most reported cases occur in northern Australia and Papua New Guinea. There have been a few rare cases from South Australia. Serological studies show that only 1 person in about every 800 of those infected with MVE virus will develop clinical symptoms and the disease itself. Of those presenting with encephalitis in Victoria in the 1974 endemic, approximately 1/3 died, 1/3 were left with residual brain damage, and about 1/3 recovered completely. So about 20% of people who become ill with severe Murray Valley encephalitis will die. Of those that survive, about 40% have permanent neurological damage, such as paralysis or brain damage. But recovery may still take several months. Treatment and therapy. Those who aren't diagnosed with MVE are usually quite sick and do require supportive care in a hospital until they recover. Currently, no vaccines exist for this virus. Your best bet is prevention against mosquito bites, including covering exposed skin by wearing long sleeve shirts, long pants, and hats, using appropriate insect repellent, and if you're able to stay and sleep in a screened in or air conditioned room, as well as use a bed net if the area where you are sleeping is exposed to the outdoors. All right, moving right along to dengue fever. Dengue is currently regarded globally as the most important mosquito-borne viral illness to date. Um, it's classified as well as an arbovirus because it is transmitted specifically by female mosquitoes, mainly of the species Aedes aegypti. This mosquito also transmits chikungunya, yellow fever, as well as Zika infection, interestingly enough. Dengue is caused by one of four related viruses, actually, dengue fever 1, 2, 3, and 4. And for this reason, an individual can be infected with a dengue virus as many as 4 times throughout his or her lifetime. The Aedes aegypti mosquito typically lives in urban habitats and breeds mostly in man-made containers like buckets, bowls, animal dishes, flower pots, and vases. They like standing water, obviously. Unlike other mosquitoes, Aedes aegypti is a daytime feeder, so its peak biting periods are early in the morning and in the evening before dusk. The female Aedes aegypti can bite multiple people during each feeding period, and her eggs can remain dry for over a year in their breeding habitat and hatch when they come in contact with water. Dengue fever is widespread throughout the tropics with local variations in risk influenced by rainfall, temperature, and unplanned rapid urbanization. After the virus incubation period of 4 to 10 days, the infected mosquito is capable of transmitting the virus for the rest of its life. Infected, symptomatic, or asymptomatic humans are the main carriers and multipliers of the virus, as they serve as the source of the virus for uninfected mosquitoes. Individuals who are who are already infected with the dengue virus can transmit the infection for 4 to 5 days via the Aedes mosquitoes after their first symptoms appear. As I mentioned, dengue virus is transported from one place to another by infected travelers. Also, vertical transmission is possible from mama to fetus. It's rare, but can happen. Also, dengue can be transmitted by exposure to infected blood. All right, moving on to mechanism of action. So, the dengue virus enters the skin along with the mosquito saliva through its bite. It then binds to and enters white blood cells, reproducing inside the cells while they move throughout the body. These white blood cells respond by producing a number of signaling proteins, including interferons and other cytokines, which are responsible for nonspecific symptoms such as fever, headache, joint, and muscle pains. These mature new viruses then bud inside the cell and are released by exocytosis. They can then enter other white blood cells, for instance, monocytes and macrophages. In a severe infection, virus production inside the body is greatly increased, and many more organs, for instance, the liver and bone marrow, can be affected. Fluid from the bloodstream leaks through the wall of small blood vessels into body cavities because of endothelial dysfunction. As a result, less blood circulates and shock may result. Furthermore, dysfunction of the bone marrow due to infection of the stromal cells leads to thrombocytopenia or low platelet levels, which can increase the risk of bleeding, another major complication. Patient symptoms. So approximately 1 in 4 people infected with the dengue virus will actually get sick. Dengue is suspected when a high fever of around 104 degrees Fahrenheit is accompanied by 2 of the following symptoms: a severe headache, pain behind the eyes, muscle and joint pains, nausea, vomiting, swollen glands, or a rash. These symptoms usually last for 2 to 7 days after the 4 to 10 day incubation period. Severe dengue is a potentially deadly complication due to plasma leaking, fluid accumulation, respiratory distress, severe bleeding, or organ impairment. Warning signs for severe dengue occur 3 to 7 days after the first symptoms, along with a drop in temperature below 100 degrees Fahrenheit. and can include severe abdominal pain, persistent vomiting, rapid breathing, bleeding gums, fatigue, restlessness, and blood in vomit. Essentially, the next 24 to 48 hours of the critical stage can be fatal. Severe dengue is classified as a medical emergency and requires immediate medical attention or hospitalization. About 1 in 20 people who get sick with dengue fever will develop severe dengue. Those who have had a dengue infection in the past are more likely to develop severe dengue, as are infants and pregnant women. Diagnosing dengue fever must be done with a blood test. It's the only way to confirm the diagnosis. So diagnosis includes virus isolation, the PCR testing, again, similar to the Murray Valley encephalitis, serology testing, and a positive tourniquet test, which determines capillary fragility. Moving right along to epidemiology. So dengue has emerged as a worldwide problem since the 1960s. This increase is believed to be due to several factors, including global warming and urbanization. Dengue is considered an endemic in more than 110 countries right now. Its estimates of the global incidence of dengue infections per year have ranged between 50 million and 200 million people, although recent estimates using cartographic estimates suggest the number is closer to 400 million. Both North and South America, Southeast Asia, and the Western Pacific regions are the most seriously affected by dengue. And actually, about 40% of the world's population, which is approximately 3 billion people, live in areas with high risk of dengue fever. In many countries, dengue is a leading cause of illness. Moving along to treatment and therapy strategies for dengue fever. So treatment of acute dengue is supportive, including oral or intravenous rehydration for mild or moderate disease, and the use of intravenous fluids and blood transfusion for more severe cases, as dehydration is extreme. There is actually a vaccine in the works for dengue, which is exciting. So the live attenuated dengue vaccine, known as Degavaxia, has been shown in clinical trials to be successful and safe in people who have had a previous dengue virus infection. That being said, it does carry an increased risk of severe dengue in those who experience their first natural dengue infection post-vaccination. Even so, it was approved in May of 2019 and is licensed and available in some countries for people ages 9 to 45 years old. In the US, the FDA approved its use in children who are 9 to 16 years old that live in areas where dengue is common, such as the U.S. territories of American Samoa, Puerto Rico, and my home, the U.S. Virgin Islands, with laboratory-confirmed prior dengue virus infection mandatory. Information on the vaccine's availability in the U.S. territories is still pending, however. So, moving on to the next slide, we'll continue with treatment. Again, just like Murray Valley encephalitis, the main method to control or prevent the transmission of dengue is to combat vector mosquitoes through the same things I listed for the MVE virus. These are just some additional points. So, disposing of solid waste properly, removing artificial man-made habitats such as this image in the upper right-hand corner, a tire with still water, perfect breeding ground for the mosquitoes. Also covering, emptying, and cleaning of domestic water storage containers frequently, and applying appropriate insecticides to water storage outdoor containers when necessary. All right, and last but not least, we have Powassan virus, which is also an arbovirus, part of the flavivirus family, which is spread to people through the bite of an infected tick. It is considered rare. However, the number of reported cases of people sick from Powassan virus has increased in recent years. So as I mentioned, the causative agent is an infected tick. They become infected when they feed on groundhogs, squirrels, mice or other rodents that have the virus in their bloodstream. The infected ticks can then spread the virus to people and other animals through their bite. You can see the 3 types of ticks listed below that are common in spreading this disease. People themselves do not develop high enough levels of the virus in their blood to infect biting ticks, so at least there's that as a good thing. Also, that means that people are known as dead-end hosts. These 3 types of ticks are primarily found in the eastern half of the U.S. The groundhog tick and the squirrel tick rarely bite people. The black-legged or deer tick, however, feeds mainly on white-footed mice and deer, are known for biting people. So these bites can result, obviously, in Powassan virus or other diseases such as Lyme disease. The ticks can attach to any part of the body, but are often found in hard-to-see areas such as the groin, armpits, and scalp. And Powassan virus can also be transmitted through blood transfusions. So people with confirmed infection should not donate blood for 6 months, up to 6 months after their illness. The incubation period is 7 to 30 days for Powassan virus. Symptoms. So many individuals who are infected with Powassan virus do not actually display symptoms, or if they do, they are quite mild. In this case, initial symptoms can include fever, headache, vomiting, and weakness. In rare cases, Powassan virus can cause severe disease, including encephalitis or meningitis. Symptoms of these severe cases include confusion, loss of coordination, difficulty speaking, and seizures. Moving on to diagnosis. Healthcare providers diagnose Powassan virus infection based on signs and symptoms, history of possible exposure to ticks that carry the virus, and of course lab tests. Laboratory diagnosis is generally accomplished by testing of serum or cerebrospinal fluid to detect Powassan virus specific IgM and neutralizing antibodies. Moving on to epidemiology. Powassan virus infections have been recognized in the US, Canada, and Russia. In the United States, cases of the virus have been reported primarily from northeastern states and the Great Lakes regions. You can see the map underneath the title on top here, the highlighted states in which cases have been found and the number associated with the amount of cases in those states. These cases occur primarily in the late spring, early summer, and mid-fall, which is when ticks are most active. The risk is highest for people who live, work, or recreate in brushy or wooded areas due to their greater exposure to the potentially infected ticks. Reports suggest that 10% of Powassan virus cases are fatal, and 50% of survivors develop long-term neurological problems, which can include acute headaches, muscle wasting, and memory problems, according to the CDC. Moving along to treatment and therapy. There is no specific treatment for Powassan virus other than supportive care. No current vaccines exist. Patients with severe meningitis symptoms often require pain control for headaches and antiemetic therapy and rehydration for associated nausea and vomiting. Patients with encephalitis require close monitoring for the development of elevated intracranial pressure, seizures, and inability to protect their airways. And with that, I will conclude. Here are my sources. I hope everyone enjoyed, and I look forward to watching and listening to all of your presentations. Thanks for listening.